Okay, so this is our final video for this week, you'll be glad to hear. And this is our second endocrine. So we're going to talk about thyroid disorder, but first of all, please, if you haven't done it yet, revise your thyroid physiology. That will make things a lot easier. We're going to do it in the same format. We'll do underpinning pathophysiology first. So in this case, we'll look very briefly at iodine deficiency. It's not a particular problem in this country yet, but it's starting to get an issue. We'll then look at the two opposites, if you like. So we'll have hyperthyroidism in the form of Graves' disease and hypothyroidism in the form of Hashimoto's thyroiditis. So we'll look at the pathogenesis of both of those. In applied pathophysiology, as usual, we'll look at the common signs and symptoms of both hypothyroid and hyperthyroid conditions, regardless really of the pathogenesis. Very briefly, let's just look at iodine deficiency, partly because it is actually the most common cause of thyroid disorder worldwide. It's not thought or considered to be a particular problem in the UK at the moment, but there are studies that are reporting that many of the UK population are mildly to moderately deficient. Iodine deficiency causes hypothyroidism, as you might expect, with goiter. It also causes cognitive developmental disorders in children during fetal life and the early years. And the most severe form of this is known as cretinism. However, even relatively small deficiencies in iodine can have an impact on cognitive function in all age groups. So what are the causes of deficiency? One of the problems, and this used to be a big problem in the UK more than anything with hill farming and things like that, iodine is lost from the soil due to flooding, which means that any crops grown in mountainous or particularly wet areas become depleted of iodine. And this is where we get our iodine from. We get it from the diet. Milk is also now known to be a good source of iodine. And this was really discovered accidentally. When they started adding iodine or giving this cow fodder that was rich in iodine to cows, and actually at the time they were also using disinfectants that were quite strongly carrying iodine. And that was getting into the food chain via the cows and getting into our milk. But milk is still a good source of iodine because of the cow fodder. Problem is, of course, we're drinking less milk these days. And if we do add milk to anything, many people are now using alternatives that don't have iodine, such as soya or almond milk. Fish, again, is also a rich source of iodine. And of course, seaweed and the sea is full of iodine that then gets into the fish, that we then eat the fish and get the iodine. The problem is, again, depending on our diets, we may not eat fish regularly enough to maintain those levels. Many countries throughout the world now have a habit of adding iodine to salt, iodized salt, which people then put on their food, and of course they're getting iodine that way. The UK won't actually do that. It doesn't like the idea of putting iodine in salt, so ours isn't. And also, of course, even if it was, we are taking less salt these days, generally. So a lot of it is coming from our diet. And you can see that the old sort of adage of having a healthy diet that includes milk, that includes fish, includes crops grown in the UK that perhaps haven't been subject to soil erosion and flooding, are good things. They will maintain our iodine levels. The problem is, you could say, well, we could just take supplements and various health food shops, and you can buy them online. You can get kelp products that will give you iodine. The problem is, a lot of these are too strong and they cause an iodine excess, which of course is going to have an opposite effect on the thyroid gland and cause lots of other health problems. In most areas where there is adequate iodine, the most common thyroid dysfunction is due to autoimmune disease. And we're going to talk about two autoimmune diseases, Graves' disease and Hashimoto's. But first, let's talk about Graves'. So this is a type 2. Remember, we talked before when we were talking about diabetes about the Jelen-Coombs classifications of hypersensitivities. This is a type 2 hypersensitivity. Diabetes mellitus, we were talking about a type 4. This type 2 hypersensitivity is a little bit different because you don't tend to end up with cells destroyed. It's antibody-dependent cellular dysfunction. So the antibodies make changes to how cells work, not necessarily destroy them. The autoantigen in this case is the thyroid stimulating hormone receptor. And of course, these receptors are found in the thyroid gland on the thyrocytes. When they're activated, of course, the thyroid gland then secretes T3 and T4. Thyroid stimulating hormone receptors, though, and we'll talk about this a wee bit later when we talk about the applied, are also found on adipocytes, so fat cells, fibroblasts, and osteocytes and various other cells. So there are TSHRs outside of the thyroid gland. TSHRs, when they're activated in the normal way by TSH binding, it causes various structural changes to the receptor to which they bind. And this is theorized to be the reason why these receptors can become antigenic, autoantigens. B lymphocytes are activated by antigen-specific T helper lymphocytes. Remember, this is T cell, B cell activation. They then produce, they differentiate into plasma cells, remember first, and then they produce antibodies to the TSH receptor. So they are TSHR antibodies or TSHR ABs. If you're talking about the antibodies, you must remember to put the receptor bit in there. They're not antibodies to TSH, they're antibodies to the receptor to which TSH normally binds. Now, these TSHR ABs, the antibodies, can have a stimulatory effect. They can also have a blocking or a neutral effect. Although in Graves' disease, what Graves' disease refers to is when those antibodies are stimulatory. So we have stimulatory TSHR ABs predominating in Graves' disease. So you can see where we're going here. You can imagine these antibodies, stimulatory, they bind to TSH receptors in the thyroid gland. So when they bind to these TSH receptors on these thyrocytes in the thyroid gland, then what happens is they stimulate the release of T3 and T4 in just the same way as TSH would. They're almost mimicking TSH. And of course, whereas TSH is regulated by negative feedback, in this case, the antibodies are not regulated. So we've got unregulated T3 and T4 production. This, of course, is going to cause thyrotoxicosis, a hyperthyroid state. So let's have a bit of a diagram to go through there. So we have a T helper cell, T helper lymphocytes, TH. That's been activated by an antigen presented in the usual way by an antigen presenting cell. It's been activated to specifically respond to TSH receptors. That is the antigen that they've been activated against. Then we have the T cells helping to activate B cells. So we have T cell dependent B cell activation. And if you remember, this always causes a strong, persistent release of antibodies. It activates B cells very effectively, much more so if you don't have T cell dependent activation. So our B cells then differentiate into plasma cells. Plasma cells then secrete specific antibodies that will then respond or bind to the TSH receptors. And of course, bear in mind that both T cells and B cells, because the key characteristics of the adaptive response are memory and specificity, we will have memory cells produced. Those memory cells will go into storage, so this isn't going to be a short-term problem. We're going to keep having this TSH receptor antibodies being produced. Our TSHR ABs then bind via their antigen-specific fragment variable regions to the TSH receptors within the thyroid gland on the thyrocytes. If they are stimulatory, which is most often the case in Graves' disease, these antibodies will stimulate the release of T3 and T4 in the same way as TSH would, then mimicking the action of TSH. Consequently, of course, we're going to have high levels of T3 and T4 being released, but not as a result of TSH binding. So why is this unregulated? Well, of course, we don't have any mechanisms to either monitor this TSHR ABs, or if we could monitor them, we don't have any mechanisms that can control them, unlike in negative feedback. So another question, what would happen to TSH levels? So normally, of course, if we have a high level of T3 and T4, we're talking about the long chemical loop here. That's monitored by the hypothalamus. And the hypothalamus, if levels are high of T3 and T4, will stop producing thyrotropin releasing hormone, TRH. If it's not releasing TRH, there will be a reduction in the production of TSH from the anterior pituitary. See, I told you you needed to look at your thyroid physiology again. So TSH levels will be low because this increase in T3 and T4 will activate negative feedback. Hashimoto's thyroiditis. Here we have a type 4 delayed type hypersensitivity. In other words, the same type of hypersensitivity as type 1 diabetes mellitus. So in this scenario, we're going to destroy cells. It involves an inappropriate or excessive autoimmune reaction, and that's what type 4 delayed type hypersensitivity is. This reaction is against endogenous antigens, in other words, host proteins, host cells, host molecules, our own body parts, if you like. In this case, autoantibodies that are produced from the activated B cells and the cytotoxic T cells, remember in diabetes we talked about this, in this case they attack various possible antigens in around the follicles and the thyrocytes of the thyroid gland. And several antigens or possible antigens have been identified. Common autoantigens really are thyroglobulin. If you remember, thyroglobulin was found in the follicles and then it was cleaved to release the T3 and T4. Thyroid peroxidase, TPO, is another common autoantigen. TPO normally converts iodide to iodine for addition to the tyrosine residues on thyroglobulin so that we can make T3 and T4. Hashimoto's thyroiditis can result in goiter or be atrophic, and we'll talk about goiter in thyroid disorder a bit later. Both forms, whether there's a goiter or not, though, show lymphocytic infiltration. In other words, we have lymphocytes, T and B cells, infiltrating the thyroid gland. And there's usually a high serum level of antibodies to TPO, thyroid peroxidase, and or thyroglobulin. So we can see those antibodies in the circulation, and we can see that the thyroid gland is full of lymphocytes. This reduced ability to secrete T3 and T4, because it's the same as in diabetes. The cells are being destroyed, they're being attacked by cytotoxic T cells, they're being opsonized by antibodies. So we end up losing the thyrocytes or reducing the number of thyrocytes. Of course, like in diabetes mellitus, we're talking glandular tissue again. So regeneration is fairly good. So a high level of destruction, though, would counteract that. In that scenario, we would have hypothyroidism because there would be a reduction in T3 and T4 being secreted. There also, because of course we're talking about an immune response here. And we're talking about an immune response that will go on and on and on because of those memory cells. So there would be a chronic inflammation of the thyroid gland. And chronic inflammation is characterized by concurrent damage and repair. So there would be concurrent proliferation of the thyrocytes while they're being destroyed, and there would be fibrosis, there would be scarring where those cells haven't been able to be replaced. because of this level of inflammation in the thyroid, because the cells are being destroyed and we get the full immune response and inflammation. Hence, it's called Hashimoto's thyroiditis. Itis, of course, always being inflammation. So what would happen in this case to TSH levels? We've got low T3 and T4. That T3 and T4 will be monitored. If it's low, of course, the hypothalamus will increase the production of TRH. You increase the production of TRH, you increase the production of TSH. So in this case, TSH would be high, but T3 and T4 would remain low because we don't have the thyrocytes to respond to that TSH. Let's look at that one in a diagram then. So in this one, I've actually put the APC in. You can see up there, antigen presenting cell. I haven't done the detail on the MHC or anything like that, but it is presenting an autoantigen. It's presenting it to a T helper cell. There's various co-stimulation going on, which I also haven't bothered adding in. So our activated antigen-specific T helper cell then, through this T cell dependent B cell activation, activates B cells. In addition, antigen-specific cytotoxic T cells are also activated. So their T cell receptors will then bind to our autoantigen. The B cells differentiate into plasma cells and memory cells. So this will be an ongoing problem because of those memory cells. When they differentiate into plasma cells, they secrete specific autoantibodies. So these autoantibodies will go off and bind via the FV to any of these autoantigens that originally activated the T helper cell. The autoantibodies cause phagocytosis through perhaps opsonization. They may cause necrosis and apoptosis, all via opsonization, complement activation, including membrane attack complex, and via natural killer cells through antibody-dependent cellular cytotoxicity. So we get the destruction of the cells, of the thyrocytes. TC cells, if you remember, they bind to autoantigens via their T cell receptor that's now antigen specific. Once they've bound, they secrete perforins and granzymes, just like natural killer cells do, causing apoptosis. Remember, the perforins assist the granzymes, which are proteases, to get into the cell. Once in, they trigger the death pathways that cause that cell to go into apoptosis. Eventually, hopefully, along will come a macrophage, and that will clear away the apoptotic bodies. Remember, this is a nice clean death. The overall result, depending on the autoantigen, is destruction of the thyroid gland and or any component of thyroid hormone synthesis or secretion. So we have now a dysfunctional thyroid gland that has been partially destroyed. What about predisposing factors, I hear you ask? Well, we can look at them separately, but both of them there is a family history, so there's a genetic predisposition. They are also linked to other autoimmune disorders. It's a key thing that people who suffer from one autoimmune disorder have the potential to suffer from another. In Graves' disease, predisposing factors are being female and under 40. Stress or illness can bring it on, including pregnancy, especially if there's already a genetic predisposition. Smoking predisposes to Graves' disease, and people who get Graves' disease who smoke are also at an increased risk of developing exophthalmos, and we'll talk about how exophthalmos develops later. Hashimoto's, however, being female again, but this time a bit older, middle-aged, whatever that is. Me, I'm still thinking middle-aged is maybe around 65. Having Graves' disease. So this is what we were saying about if you have one autoimmune, you can develop another. But in this case, if you think about it, you're overstimulating those thyroid hormone receptors in Graves' disease, which ultimately could lead to actually producing autoantigens that then stimulate the type 4 hypersensitivity, where the thyroid gland starts getting destroyed. Some drugs stimulate Hashimoto's, and conversely, not smoking. So smoking, if you smoke, then you're likely to get Graves' disease. If you don't smoke, then you're more likely to develop Hashimoto's. Smoking decreases the risk of hypothyroidism and thyroid autoantibodies. Not recommended that you tell your patients to go smoke, though, to stop them getting Hashimoto's. Okay, so a quick thought about the effects of thyroid hormones. Because when we know the effects of thyroid hormones, a lot of the signs and symptoms of hyper or hypo we can work out. Many T3 receptors are bound to sequences of DNA. In other words, they're little receptors that bind T3, and T3 in this case is acting as the transcription factor. So it will stimulate protein synthesis. Along comes T3 will bind, along comes RNA polymerase, unzips, pairs up the ribonucleotides, and off we go with transcription and translation and protein synthesis. These are the genomic effects. Genomic because genes. Non-genomic receptors that combine T3 and in some cases T4 are found in the plasma membrane, within the cytoplasm, and within cellular organelles. So as you can see, there are many, many intracellular receptors depending on that cell. These non-genomic receptors use a range of second messenger signaling mechanisms to initiate various signaling cascades. And if you remember when we talked about signal transduction in physiology, you can appreciate that A can be very complex, but also can end up activating through phosphorylation lots of different cascades. So the non-genomic actions, where T3 or T4 binds outside of the DNA, the non-genomic actions include modulation of membrane transport mechanisms. So, for example, ion channels, and in some cases pumps, the action of ATPase pumps. Increased oxidative phosphorylation, because, of course, thyroid hormones increase basal metabolic rate, so you're going to need more ATP. So they stimulate oxidative phosphorylation and ATP synthesis. Thermogenesis via uncoupling proteins in the electron transport chain. Now, uncoupling proteins are just little channels that get between the proton pumps, basically, and ATP synthase with its little rotor. And the uncoupling proteins allow the H+ that's accumulated in the intermembrane space of the mitochondrion to come back through into the matrix without going through ATP synthase. So this H+ coming through the uncoupling proteins doesn't synthesize ATP, but it does produce heat. Often the oxidative phosphorylation, as you can see, is upregulated, so there's no actual loss of ATP by putting in these uncoupling proteins. Mitochondrial gene transcription. Remember, mitochondria have their own DNA. Therefore, they can replicate. And this is important if you suddenly increase your activity levels. We need more ATP. To get more ATP, we might need more mitochondria within cells so they can replicate. So thyroid hormones upregulate the number of mitochondria. They enable them to replicate. And upregulation of many metabolic or signaling mechanisms. Thyroid hormones are all about upregulating. We need to talk a little bit about deiodinases. We've met one of them, although we didn't give it its proper name. If you remember, T4 is inactive. So when T4 enters cells, usually it has to have one of the iodines cleaved off to make it T3 before it can become active. And that was done by a deiodinase. That enzyme cleaves off an iodine. But there are other deiodinases that have different effects. So most cells can actually regulate the conversion of inactive T4 to active T3 through deiodinases. Another deiodinase can actually deactivate T4 and T3. D1 is found in the liver, the kidneys, and the thyroid. D1 provides T3 for the circulation, and it also serves as a scavenger enzyme for iodide from the peripheral tissues so that we can recycle it. If you remember, TPO will then convert it to iodine in the thyroid gland for addition to those tyrosine residues. D2 converts T4 to the active hormone T3. So when we talked before in physiology about this happening in cells, we were actually talking about D2, deiodinase 2. When it converts it, it's mainly for use within the cell, but some can actually be released into the circulation. Some of the converted T4 can be released as T3 into the circulation. D3 inactivates, really. It converts T4 and T3 to their inactive metabolites. What this actually means is that T4 becomes inactive reverse T3. Sorry for the name, but that's what it's called. T3 becomes T2, and these are both inactive, so they won't bind within the cell. Of course, this would whole situation, if cells produce these all of the time, all at the same time, then the cells would be a bit confused as to what was happening. So cells generally only synthesize one deiodinase at a time in response to various signaling mechanisms. D2 and D3, the last two that we talked about there, help to regulate tissue levels of T3 regardless of systemic levels. So they can actually attenuate the effects of hyper or hypothyroid disorders within the cells themselves. But because of this, there can be an abnormal indication of cellular levels by looking at blood levels, because the cells will be busy either inactivating or converting what they've got. Which brings us on to applied pathophysiology of thyroid disorders. I just thought Tigger and Eeyore were completely appropriate here. Tigger, of course, being hyperthyroid and Eeyore hypo. Well, we've got to start with goiter, haven't we? In Graves' disease, if you remember back when we talked about the thyroid disorders, we talked about TSH binding to thyrocytes in the thyroid gland not only stimulates the production of T3 and T4, it also acts as a mitogen. Anything that acts as a mitogen causes growth. So using a second messenger system, it stimulates the proliferation of the thyrocytes and consequently thyroid gland hypertrophy. The thyroid gland gets larger. Now, normally TSH, of course, is highly regulated. So this doesn't lead to enlargement, it just replaces old thyrocytes. In Graves' disease, these thyroid stimulating hormone receptor antibodies have the same action as TSH, so they act as a mitogen, but of course they can't be controlled by negative feedback. So there's uncontrolled excessive proliferation of the thyrocytes and hypertrophy of the thyroid gland. So the thyroid gland is larger than normal. Goiter can actually happen in euthyroid conditions. Euthyroid means that thyroid function is normal, but there's a goiter. Goiter can be nodular or diffuse, and if it's left untreated, then there can be constriction issues, or the nodules can present as a carcinoma risk. So in those circumstances, then surgery will be indicated. Otherwise, it can be left untreated. And smokers, again, like exophthalmos, they may be more prone to goiter. What about goiter in Hashimoto's? Now, this varies. There may be goiter. If there is goiter, it's due to thyrocyte hypertrophy caused by TSH overstimulation. So bear in mind there's low levels T3 and T4. So TRH will be increased, therefore TSH will be increased. We've already said that TSH levels will be high. That TSH will bind, act like a mitogen, and there may be hypertrophy, so thyrocyte proliferation and hypertrophy of the gland because of that, because of TSH overstimulation. There may be metaplasia. Metaplasia is where cells become a different type of cell. They convert into something else gradually over time. So in this case, the thyrocytes become large oncocytes known as Hürthle cells. And these Hürthle cells can form benign or sometimes malignant tumors. And as we said before, there's also going to be a chronic inflammatory condition going on, and there's going to be lymphocyte infiltration. Both of these take up space, they make the glands swell, so that potentially could make the thyroid gland larger. There may also be some fibrosis. As I said, this is a chronic inflammatory condition. Fibroblasts are quite prevalent in chronic inflammatory conditions because you have the attempts to repair, but of course the attempts to repair are being thwarted by more damage. So fibrosis is quite common in chronic conditions. In this case, what happens, and we'll come back to this when we look at liver cirrhosis, this fibrosis forms these tight bands, and those tight bands end up separating little nodules of thyrocytes that are all trying to regenerate, of course. So you end up with these nodules differentiated by bands of fibrosis, and they give that nodular appearance or feel to the goiter. Later on, what often happens is, if it goes untreated, the follicles may atrophy. So in other words, they may shrink down. And of course, as a result of this, the whole thyroid can shrink down. Probably will feel quite firm because of fibrosis, may even still be nodular, but it will be small. Myxedema, acropathy, and exophthalmos then. Those are our other more obvious symptoms. And often these are due to the proliferation of fibroblasts in the skin. T3 stimulates this. So in conditions where there is a raised T3, there will be increased proliferation of fibroblasts. These fibroblasts, if there's any inflammation going on and an autoimmune response, there'll always be some degree. If cytokines are released, they will activate the fibroblasts. Fibroblasts secrete glycosaminoglycans, GAGs, particularly a well-known one called hyaluronic acid. And I actually have moisturizers with this in, and you may have seen moisturizers advertised with this in because it helps to plump up the skin. It draws water to itself. So fibroblasts secrete these. TSH receptors, if you remember, we said are found in other places other than the thyroid gland. So they are found on fibroblasts, adipocytes, fat cells, and pre-adipocytes. Pre-adipocytes are specialized fibroblasts. So if there are high levels of TSH, as in hypothyroidism, Hashimoto's negative feedback, or if there are TSH receptor antibodies, as in Graves', they will bind to these TSH receptors on the fibroblasts and they will stimulate the secretion of these glycosaminoglycans. GAGs are highly polar polysaccharides, and as I said before, like hyaluronic acid, they all attract large amounts of water. That's what they do. When they do this, they form hydrated, so watery, intercellular matrices, so matrices around the cells. So you end up with the gags attracting water and plumping out between the cells. This forms the gel-like ground substance of connective tissue. Myxedema, or if you're American, mixed edema, is caused by the collection, the deposition of these gags in the tissues. This then draws water in and it creates a sort of mucoid, non-pitting edema. Pretibial is the classic place, and this is probably down to gravity. So the gags and the water fall down due to people standing up or legs hanging down, and you've got this accumulation around the feet and the ankles and lower legs. This myxedema may also occur in Hashimoto's, as we said, probably due to the increased secretion of TSH following negative feedback. But it usually only occurs in severe, untreated hypothyroidism. And you will see terms used like myxedema coma in a hypothyroid state. Acropathy it's a bit like clubbing. You get the accumulation of these gags and water, obviously, around the distal fingers, and this causes swelling and raised, sort of rounded nails, similar in appearance to clubbing. Which brings us on to exophthalmos. Less seen these days, and it's quite an old-fashioned term in its own right. These days, other terms tend to be used. Generally, thyroid disorders are treated, Graves' disease is treated earlier than exophthalmos develops. But it used to be quite a common symptom, and it's also a very obvious symptom. And again, we have myxedema, but in this case, we've got it in the bony orbit. Also, alongside some fibrosis. And you can imagine bony orbit, it's pretty hard. So there's going to be a force pushing out the eyes. So you end up getting a bulging eye and retracted lids, because all this myxedema and fibrosis can't go anywhere because it's in a hard shell. The other problem with this is that this pressure within the orbit compresses one of the veins, the superior ophthalmic vein. It's not better than the others, it's just at the top of the orbit. You can see it there. So any swelling will push out on this, it will compress it. This means, because this is a vein, then the outflow of blood from the orbit is going to be inhibited. So we've got blood coming in through arteries, but it can't get out through the veins. As a result, you're going to get increased hydrostatic pressure in the orbital vessels. And when you get increased hydrostatic pressure, you invariably get transudation from the vessels into the surrounding tissues. So transudation of water from the vessels and increased vessel size, the vessels are going to be quite engorged, contributes to the orbital pressure. Which brings us on to the major cardiovascular and pulmonary changes in both hyperthyroidism and hypothyroidism. Before we do a little bit of revision, if you remember, blood pressure is cardiac output times peripheral resistance. Cardiac output being the amount of blood pumped out over a minute, peripheral resistance being mainly related to vasomotor tone. Cardiac output is the product of stroke volume, the amount of blood per beat, times the number of beats per minute. So stroke volume times heart rate. Stroke volume is about end diastolic volume. End diastolic volume being preload. Preload is about venous return, which is mainly affected by blood volume. End diastolic volume minus end systolic volume. End systolic volume being the amount of blood left in the chambers after systole, after contraction. End systolic volume, if you remember, is reduced by increased contractility. So the strength of contraction will leave less blood in the chambers, less end systolic volume, which of course will increase stroke volume. End systolic volume, though, is increased by afterload. This is about the amount of pressure that contractility has to push against. If you remember, afterload was things like sticking aortic valves or systemic hypertension. It's the back pressure that the blood has to be pushed against. Let's start with hypothyroid then. As you might expect, of course, hypothyroid conditions, everything tends to get upregulated. So cardiac output is actually increased by 50 to 300%. It's also associated with systolic hypertension and increased pulse pressure. In other words, the difference between systolic and diastolic BP. If systolic is going up, diastolic staying the same, there will be increased pulse pressure. This is because peripheral resistance and end systolic volume are decreased. End diastolic volume and heart rate are increased. So let's look at peripheral resistance first. Peripheral resistance, of course, is reduced by vasodilation, and that keeps diastolic blood pressure in particular low. And in this case, in hypothyroid conditions, vasodilation is caused because T3 has a normal function of relaxing smooth muscle within the vasculature, if you remember the tunica media of the vessel walls, by altering various intracellular signaling pathways. So if there is an excess of T3, as in hypothyroid, then there will be greater relaxation of vascular smooth muscle cells. T3 also induces, so it causes the synthesis and release of nitric oxide. And nitric oxide, of course, is a strong local vasodilator. So we've got two mechanisms there, both contributing to vasodilation. Vasodilation will reduce peripheral resistance, which keeps the diastolic blood pressure low, even though cardiac output is increasing. So let's move on to end diastolic volume. End diastolic volume, remember, is increased. It's increased because one of the things is T3 stimulates erythropoietin synthesis. So it increases the release of erythropoietin. Of course, that causes erythropoiesis, and we get increased blood volume. due to an increase in erythrocytes, increased hematocrit. The T3 induced reduction in peripheral resistance that we just talked about, that vasodilation, activates RAS because there's going to be reduced pressure in the glomeruli. Plus also, in addition to RAS being activated, T3 directly stimulates renin secretion, also activating, of course, RAS, because renin is the R in RAS. Because of this, that we get a reabsorption. Remember what RAS does in the renal tubules. It stimulates with angiotensin 2, aldosterone, ADH. They all stimulate the reabsorption of water and sodium from the renal tubules. When we reabsorb it, that increases blood volume. If you increase blood volume, of course, that then increases venous return and increases preload and increases end-diastolic volume. Another effect of T3 is increases the synthesis and the expression of calcium pumps in the sarcoplasmic reticulum. So what this causes is more efficient pumping of calcium back into the sarcoplasmic reticulum, because remember, these pumps come into effect really after contraction by pumping the calcium back in, away from troponin. So we get more efficient pumping of the calcium back into the sarcoplasmic reticulum. Because of that, we get faster relaxation. If you get faster relaxation, it will prolong diastole. You will have longer for passive filling of the heart chambers. If you've got longer time for passive filling, of course, you're going to get more blood in. So you're going to get greater preload. Another effect that has an impact on the pumps, the calcium pumps, is that T3 inhibits phospholamban. Phospholamban is a physiological inhibitor of calcium pumps. So, okay, we're losing our inhibitor that would inhibit those pumps because it itself is being inhibited by T3. So end systolic volume is decreased, which is going to give us greater stroke volume, greater cardiac output, theoretically. So end systolic volume is decreased because what happens is T3, there's always a link between thyroid hormones and the sympathetic nervous system. They both are known to upregulate just about everything, and they work very closely together. And one thing that T3 does is it upregulates the expression of beta-1 adrenoreceptors. Not only the expression, but also the affinity. If you remember, expression is going to be about the numbers of beta-1 receptors that are displayed on the plasma membrane, and also affinity is increased. Affinity is about their attractiveness for their ligand, in this case, primarily noradrenaline, although they do bind adrenaline as well. So what happens is the amount of noradrenaline doesn't necessarily change, but it is potentiated. It has a greater effect because it has more receptors to bind to, and it's more likely to bind to those receptors. This, in terms of end systolic volume, is going to cause an increase in calcium release into the contractile myocytes and stronger contractility. If you remember, beta-1 adrenoreceptors not only bind noradrenaline to increase heart rate, they also bind noradrenaline to increase contractility via the release of calcium to troponin in cardiomyocytes. So we get that stronger contractility, which is going to reduce ESV. T3 also increases the synthesis and the expression of ryanodine receptors. Remember these? These ryanodine receptors, if you remember, are stimulated, they're voltage sensitive, and they stimulate the release of calcium from the sarcoplasmic reticulum. So if we have more ryanodine receptors in our T tubules, we are going to stimulate more calcium release from the sarcoplasmic reticulum. So again, there will be more calcium to bind to troponin, so this will increase contractility. Normally, contractility has to battle against afterload. So afterload is the opposing force, if you like. But in this case, there is decreased afterload. Because if you remember, we said right at the beginning, peripheral resistance is reduced because there is vasodilation. That means that there is going to be less pressure for the contractility to push the blood out against. So that will also contribute to a decrease in end systolic volume. So we've increased end diastolic volume and we've decreased end systolic volume. Therefore, we've increased stroke volume and increased cardiac output. But remember, peripheral resistance is reduced. Which leaves us with heart rate. And I think you can probably work this out. Remember, we just said that T3 increases the expression and the affinity of beta-1 adrenoreceptors. Now remember what they do in relation to heart rate. Remember G stimulatory proteins, adenylate cyclase, cyclic AMP, sensitization of our funny channels. Yes, exactly, that's why heart rate is increased. So T3 stimulates beta-1 upregulation, potentiates noradrenaline. This is more likely to activate GS, stimulatory G protein, that then gets to produce more cyclic AMP and sensitizes those funny sodium channels. Remember, the pre-potential starts with sodium channels opening, and the slow calcium channels that fill in the rest of the pre-potential and take the pre-potential up to threshold and then on into depolarization with the fast calcium channels. So what we end up getting is that shorter, steeper pre-potential, which brings together the peaks of depolarization, each one being a heartbeat. So of course we get faster depolarizations and faster heart rate. The other thing that T3 does, it also stimulates the synthesis and expression of both of our pre-potential channels. So both the funny sodium channels that open first and the slow calcium channels. So again, if we've got more of them, then that's going to give us that shorter, steeper pre-potential. Sometimes, because of this increase and the other cardiovascular changes, the patient may report experiencing palpitations alongside it, and also arrhythmias may even develop. So increased heart rate and increased stroke volume both contribute to increasing cardiac output. But blood pressure doesn't rise, of course, because we've got reduced peripheral resistance. Only systolic blood pressure increases. All these changes in the end may end up with heart failure. And this is because in hyperthyroid conditions, more of the ATP synthesis is uncoupled. Remember those uncoupling proteins. So we have less ATP synthesis. As a result of that, remember we said what happens with the uncoupling proteins is that H plus in the intermembrane space is diverted through the uncoupling proteins, resulting in heat rather than ATP. But it does mean that there is potentially less ATP for the metabolic functions and contraction. If you think how much ATP that will take in cardiomyocytes. In addition, of course, what we've done is we've increased the calcium pumps. These are calcium ATPase pumps. They require ATP every single time they operate. So that's also going to deplete the ATP stores in the cardiomyocytes. As a result, what happens is the cardiomyocytes cannot contract as effectively, so contractility may go down. But actually what may happen is that thyroid hormone receptors and the plasma levels of T4 and T3 are decreased because of heart failure. Consequently, the heart may develop a situation where it's operating in a hypothyroid status, which is going to give even more diminished contractile function. In hypothyroid conditions, as you might expect, we get the opposite effects in terms of cardiovascular status. And diastolic volume and heart rate are decreased, and systolic volume and peripheral resistance are increased, so directly opposite. Because cardiac output is decreased, systolic BP in this case remains low. And diastolic volume is decreased because in this case we're going to have reduced calcium pump expression. So we're also going to have increased phospholamban inhibition of the pump, so the direct opposite that we had before. In this case, we're going to have a reduction in the passive filling time. There won't be as much time for the chambers to fill and to develop a decent amount of end diastolic volume. And systolic volume is going to be increased, of course, dropping stroke volume because there's more left in the chambers. Contractility is reduced because, again, the opposite, whereas before we had an increase in the expression of beta-1 adrenoreceptors, in this case we've got a reduction. So that's going to inhibit noradrenaline rather than potentiate it. There's also going to be a reduction in ryanodine receptors. So we haven't got the same stimulation, the same calcium release to bind to troponin to give a strong contractility. So that's going to increase end systolic volume. The other side of end systolic volume, of course, is afterload. In this case, afterload is going to be increased, so there's going to be more resistance for this weak contractility to push against. The afterload is increased by vasoconstriction, which gives us increased peripheral resistance. Heart rate is reduced. Again, we've got, in this case, a downregulation of beta-1 adrenoreceptors. So there's fewer of them. Their affinity is not as strong. We also have fewer funny channels, fewer sodium channels, fewer slow calcium channels. So we're going to have a slower prepotential, a longer slope, driving those depolarizations further apart and reducing heart rate. As we just suggested, peripheral resistance is increased because of vasoconstriction. And what this shows us is a raised diastolic BP. And that's going to give us a narrow pulse pressure. There is vasoconstriction because, again, we're talking about opposites. In this case, we have a reduction in T3. Therefore, we have a reduction in its effect in relaxing vascular smooth muscle cells. We also have a reduction in T3's promotion of nitric oxide secretion because we don't have the T3. Also in hypothyroidism, there is a reduction in the synthesis of endothelin-derived relaxing factor. Clues in the name, really. EDRF. This is a vasodilator because it relaxes the smooth muscle cells and it's secreted by the endothelial cells. In this case, in hypothyroidism, there's a reduction in its synthesis. It's a vasodilator, so of course it can't counteract the vasoconstriction. In addition, there is an increase in LDL and blood cholesterol, which will make a small contribution to peripheral resistance, to the sluggishness, the gooiness of the blood. And this is because of ineffective hepatic clearance, because there are fewer hepatic LDL receptors in hypothyroidism. One final note is that the cardiac effects are complex. And if this is your particular field, you may want to look at some further reading. I would suggest more of the scientific articles. The other issue is that research often conflicts or it's theoretical. So there are constant changes in terms of what people are finding out. And there's the complexity of plenty of interactions as to what's going on in these signaling processes. In terms of pulmonary effects, in hypothyroidism, you tend to get exertional dyspnea and exercise intolerance. And this is because at rest, there is a hyperdynamic circulation. You're already, if you like, fired up. Consequently, when you put extra call on that, when you go off and do some exercise, there's an inability to increase the heart rate or lower vascular resistance even further to cope with the additional demands that you're putting on the system. This then is compounded by a systemic muscular weakness. We'll talk about it in a little while. In hypothyroidism, there is a depressed ventilatory drive. So this, on a normal situation, this might result in alveolar hypoventilation. That might actually progress on in severe hypothyroidism. the response to hypoxia or hypercapnia is reduced. So that sort of extra ventilatory drive as a result of the chemoreceptors is inhibited. Also, of course, because you've got reduced cardiac output. So think about this. We've talked about this before. Blood is being pushed out of the heart in a forward direction, if you like. Because it can't be pushed out effectively, there is backward failure. On the left side of the heart, this causes backward failure into the pulmonary capillaries. So the pulmonary capillaries become engorged. They can't push their blood through the heart because the heart can't pump out into the systemic circulation as effectively as normal. This engorgement of the capillaries leads to increased hydrostatic pressure and transudation into the interstitial area and also into the alveoli. So you end up getting a pulmonary effusion, which of course is going to inhibit gaseous exchange and pulmonary function. And again, in hypothyroidism, there is also muscular weakness. This muscular weakness in both cases is going to have an impact on the respiratory muscles. They are skeletal myocytes at the end of the day. Of course, fatigue is another key symptom in both opposite conditions, in hyperthyroid and in hypothyroid. And you can probably more or less work out that the main mechanisms that are happening here. And it is the classic presentation, really, of tired all the time. One of the first things you might think about is there a thyroid condition here? In hyperthyroidism, of course, you've got increased basal metabolic rate, you've got increased cellular metabolism. That's going to require lots of ATP. Lots of ATP requires a lot of stores to be used up to make that ATP. So increased metabolism depletes the stores of glycogen, of fats, of essential vitamins, and of minerals. In hypothyroidism, for reasons that we're not going to go into, and some of them aren't really that well known, the mechanisms at least, in hypothyroidism, it's commonly associated with restlessness, with tremors, with insomnia, all those sorts of things. And all of these can add to fatigue. There is also, of course, potential heart failure in severe untreated hypothyroidism, which is also going to contribute to fatigue. In hypothyroidism, there is a decreased metabolic rate. Everything is slowed down. So there is going to be low glucose metabolism and ATP production. Cardiac output is reduced, so there's going to be reduced tissue perfusion and reduced perfusion to the brain. Anemia is also a potential problem. Remember we said that T3 stimulates erythropoiesis, and there we were talking about the increased erythrocytes in the circulation adding to preload. If there isn't T3, there's going to be reduced erythropoiesis. So we're going to have fewer erythrocytes to carry oxygen around to the cells. There is also often bone marrow dysfunction in hypothyroidism. So of course we might not actually be able to produce those erythrocytes so effectively. In autoimmune disorders, remember this is an autoimmune disorder and often they go hand in hand with others, there may be the loss of intrinsic factor due to concurrent autonomic disorders. Loss of intrinsic factor, of course, intrinsic factor is required for vitamin B12 absorption. So if B12 absorption is reduced, we're going to have true pernicious anemia. Muscle weakness is slightly different to generalized fatigue. In hypothyroidism, of course, we need more energy, we need more ATP. This may result in proteolysis, the breakdown of proteins for energy, which is going to deplete muscle protein. It's going to be very difficult to maintain or increase skeletal myocytes because we're depleted in muscle protein. Another problem that's also linked to tremor is the reduction in acetylcholinesterase. So T3 reduces acetylcholinesterase. Acetylcholinesterase, if you remember, is the enzyme that breaks down acetylcholine, ACH, in the synaptic cleft. Therefore, if it's not broken down in the synaptic cleft, it can keep on binding to those ligand-gated sodium channels and stimulating the myocyte, the skeletal myocyte, at the neuromuscular junction. So we get overstimulation at the neuromuscular junction because acetylcholinesterase is reduced. In addition to this, there may also be degenerative structural changes at the neuromuscular junction. And as I say, this is often also linked to the tremor that's seen in hypothyroidism. Calcium release from the sarcoplasmic reticulum is also thought to be directly stimulated by T3. So if there's an excess of T3, there is an increase in calcium release from the sarcoplasmic reticulum in skeletal myocytes. So this is going to cause overstimulation of troponin, overbinding of troponin, overstimulation, which of course all takes ATP. So it's going to make those muscles weaker because of overstimulation. In hypothyroidism, weakness and aches are due to low ATP synthesis. That's fairly logical. And of course, as we said above, we're going to have the opposite. We're going to have a reduction in T3 stimulated calcium release. Weight again is fairly obvious. Weight loss in hypothyroidism with increased appetite usually is due to increased lipolysis, breakdown of fats for energy, breakdown of proteins, proteolysis for energy. This is going to cause weight loss. It also tends to stimulate appetite through the appetite centers in the brain that monitor the levels within the blood. Weight gain in hypothyroidism, of course, we've got a low basal metabolic rate. So we're not burning up the fats. And we've got a low need for energy. So we're not going to be making as much ATP, not going to be burning so much up. It's the equivalent really of the overeating and not exercising. So our final sign and symptom that we're going to look at in this applied section is heat or cold intolerance. In hypothyroidism, heat intolerance is going to be due to that increased basal metabolic rate, which is going to create heat. Remember, all those things going on, all that ATP synthesis, it's going to cause thermogenesis. It's going to increase heat. Also, remember our uncoupling proteins. Remember, they were upregulated. Their role is to provide heat rather than ATP. So, although we're increasing the rate of cellular respiration, we're actually increasing the amount of heat through uncoupling proteins. There is also increased brown fat oxidation. Remember, we talked about this in terms of producing heat to meet a set point when we were talking about fever. So in this case, this is activated by T3 directly, and because T3 activates the sympathetic nervous system. Both of these increase brown fat oxidation, and brown fat oxidation is all about producing heat when we need it. It is adaptive thermogenesis. In hypothyroidism, of course, we have the opposite. We have cold intolerance. So we've got a low basal metabolic rate. And if ever you're feeling really sleepy or you wake up in the middle of the night, everything's reduced basal metabolic rate has gone down into your boots, and generally you feel a bit cool. So decreased basal metabolic rate is linked with decreased thermogenesis. Also, decreased brown fat oxidation, so decreased adaptive thermogenesis. Which brings us to the end of applied. Other signs and symptoms are available, but we really can't cover them all. And again, as I said about cardiovascular, it can all get very complex because of the breadth of the effects of thyroid hormones and the interaction of the different mechanisms, and also the fact that some of them basically are still being argued about. And there would just be too much. You probably think you've had enough already. So we're not going to cover anything else on thyroid disorders anyway. And I'll see you in your live session.